Hello and welcome. Today we're diving deep into Lemierre's syndrome. You might have heard it called the forgotten disease, and for good reason. It almost disappeared thanks to penicillin, but, well, it's making a comeback. So we're going to take a closer look at its clinical significance. To really grasp what we're up against, just look at this number, 90%. Let that sink in for a moment. That was the mortality rate in André Lemierre's original case series back in 1936. Out of 20 patients, 18 died. That really frames the gravity of this syndrome. It starts as a simple sore throat and can spiral into a fatal condition fast. So here's our game plan. We'll start by looking at the classic clinical picture of this forgotten sepsis. Then we'll get into the microbiological detective work needed to nail the diagnosis. After that, we'll cover the best therapeutic protocols we have today. We'll also touch on infection control, the long-term consequences, and we'll wrap up with a few clinical vignettes to make sure it all sticks. Okay, let's jump right in. Section 1, the clinical picture. We're going to unpack how Lemierre syndrome actually shows up and why it's called post-anginal sepsis, which literally means sepsis that happens after a sore throat. So what is it exactly? Well, Lemierre syndrome is, by definition, a septic thrombophlebitis of the internal jugular vein. It's a nasty complication of an infection in the head or neck, usually starting as pharyngitis. The infection basically invades the space next to the pharynx, causing a blood clot in the jugular vein that gets infected. What's really striking is that it tends to hit otherwise healthy young adults, which is a key puzzle for immunologists. This slide really lays out the whole catastrophic cascade. It all starts with a run-of-the-mill throat infection. This creates the perfect environment for anaerobic bacteria to thrive, often forming a peritonsillar abscess. From there, the infection eats through the muscle into the lateral pharyngeal space and invades the nearby internal jugular vein. This triggers the thrombophlebitis, the infected clot. And the final, most dangerous step? That infected clot breaks apart, sending septic emboli into the bloodstream. The epidemiology here is pretty startling. You can see the incidence in adolescents and young adults is up to 20 times higher than in the general population. The leading hypothesis for this huge jump has to do with age-related changes. Things like shifts in the pharyngeal lymphoid tissue and the local microbial flora, which might just open the door for Fusobacterium to invade. Next up, let's talk about the microbiological investigation. This is the detective work. Getting a definitive diagnosis for Lemierre's completely depends on getting the lab work right, making this a super critical phase. All right, this part is crucial. Because the main culprits are these finicky anaerobic bacteria, how you collect and transport samples is everything. We're talking multiple sets of blood cultures, making sure you get enough volume into both the aerobic and anaerobic bottles. If you aspirate any pus or take a tissue biopsy, it has to go into an oxygen-free transport system to keep the bacteria alive. Honestly, a failure right here in this pre-analytical phase is a huge reason why you might get a culture-negative result. And here's our primary culprit. In over 80% of cases, it's Fusobacterium necrophorum. This is a gram-negative, obligately anaerobic rod. You might find other bacteria along for the ride, but F. necrophorum is the main pathogen. It's got all the right virulence factors, endotoxins, leukotoxins, and so on, that let it invade tissue and kick off that whole thrombosis process. Now that we've identified our pathogen, let's talk about how we fight it. Section 3, antimicrobial protocols. The key here is to start treatment immediately and empirically, meaning you're targeting the most likely culprit, anaerobes, before you even get the final lab results back. For adults, the evidence points to a strategy of high-dose intravenous penicillin or amoxicillin plus a beta-lactamase inhibitor like clavulanate. For kids, you're often looking at something like piperacillin, tazobactam, or a carbapenem. And if you have a significant penicillin allergy, the standard alternative is a third-gen cephalosporin combined with metronidazole. Now, this isn't a quick course of antibiotics. Therapy is long, usually 2 to 6 weeks, and you tailor it as you get more clinical data and culture results. Section 4. Let's zoom out to infection control and lab safety. Given what this pathogen is,
You need specific protocols to protect healthcare workers and to make sure the diagnostic samples aren't compromised.
So, Fusobacterium necrophorum is classified as a biosafety level 2 organism. That means standard precautions are a must, but you have to pay special attention in the lab to any procedure that might create aerosols. And while Lemierre's itself isn't usually a reportable disease, if you see a weird cluster of cases or find a highly resistant strain, that's something public health authorities would want to know about to keep an eye on any new trends.
And now, we get to the consequences. Section 5. Systemic complications. This is where you see the true frightening potential of Lemierre syndrome, when that infection in the neck spreads through the entire body.
This is really the central question of the whole syndrome, isn't it? How can something so incredibly common, a sore throat, morph into a multi-system, life-threatening disaster? The answer, as we've seen, lies in that trail of septic emboli.
The systemic spread follows a predictable and very dangerous path. The bacteremia triggers sepsis, which can lead to septic shock. Those septic emboli from the jugular vein travel straight through the right side of the heart and into the lungs. This is what causes the pulmonary infarcts, abscesses, and empyema. It's a hallmark of the syndrome. From there, the bacteria can seed anywhere, leading to multi-organ failure, abscesses in bones and joints, and even devastating neurological or cardiac problems.
You know, after all of that incredibly heavy information, you have to take a step back. It really is a testament to the microbial world's cunning that a simple sore throat can escalate like this. You could say it's the ultimate overreaction, proving that even bacteria have a flair for the dramatic.
All right, to wrap things up, let's do a quick knowledge check. We'll apply some of these concepts to a couple of clinical scenarios.
First question. So you've got a classic case. A 22-year-old comes in. They had a sore throat. Now they have raging fevers, chills, and they're really tender along one side of their neck. Imaging confirms it. Internal jugular vein thrombophlebitis. What's the go-to empirical antibiotic regimen?
The answer is a beta-lactam/beta-lactamase inhibitor combination, something like amoxicillin clavulinate or piperacillin tazobactam. And the rationale is simple. You need robust empirical coverage against Fusobacterium necrophorum, and that includes any strains that might be producing beta-lactamase. It's all about hitting it hard and early.
Question 2. Of all the really terrible complications we just talked about, which one is considered the defining hallmark feature that comes directly from that infected clot in the neck?
The correct answer here is septic pulmonary emboli. This is the key pathognomonic feature, the smoking gun, if you will. That infected thrombus in the IJV is the direct source. Little pieces break off, travel through the right heart, and get lodged in the pulmonary arteries. That's what gives you those characteristic cavitating nodules and abscesses you see on a chest scan.
And for our final question, let's circle back to the lab. From a pure microbiological perspective, which organism is the undisputed king of causing Lemierre syndrome?
And the answer, of course, is Fusobacterium necrophorum. Its specific virulence factors make it uniquely capable of breaking through our mucosal barriers and starting that whole thrombotic mess. Its pathogenesis is just a powerful reminder of the very delicate balance within our own microbiome. And the reemergence of this forgotten disease really makes you wonder what other pathogens might be waiting in the wings to reappear as antibiotic pressures continue to change. Thanks for joining this Explain.